Presento a Miguel Cendoroglo con la conferencia La calidad es el camino a la sostenibilidad. Sí se puede. El doctor Cendoroglo es médico con máster y PhD en nefrología de la Universidad Federal de Sao Paulo. Actualmente se desempeña como director médico y superintendente del Hospital Israelita Albert Einstein en Sao Paulo, Brasil, un hospital inmenso y que ha sido evaluado como el mejor hospital en los últimos 5 años por la revista América Economía. Es profesor asociado de medicina en la División de Neurología de la Universidad Federal de Sao Paulo, profesor asistente de neurología en la Escuela Tufts de Medicina en Boston, Massachusetts, y docente en el INSPER Albert. En 2011 realizó el curso de gestión avanzada en la Escuela de Negocios de Harvard. Conociendo que el doctor Cendoroglo tiene como idioma materno el portugués, él en un gesto muy lindo ha decidido hablar con nosotros en inglés. Muchas gracias, doctor.
Bom dia, muchas gracias por la invitación. Es un grande honor para mí. Y encontré muchos amigos, estoy haciendo nuevos amigos aquí. Voy a hablar en inglés porque uno de mis amigos, Ezequiel, me dice ayer que cuando hablo portugués un poco más rápido es como coreano para él. Y mi portuñol no es mejor que esto. Entonces, I'm sorry, but I will continue in English. I'm going to show you. Can I have the slides? Oh, there. I'm going to show you some positive experiences, things that worked right in our institution. Not everything always works right. We have had many failures as well with trials for improvement. But what we're trying today is to learn more from these experiences and to fail fast and always fail forward. Try more. And of course, try with more care. Select what we're going to do based as best as we can. Base these decisions on evidence. So I'll tell you initially a little bit about Albert Einstein. Not everybody knows about us. So it's a rather young hospital or healthcare system. It was inaugurated in 1955. It was led since the start by the Jewish community in São Paulo. So we carry the values of the Jewish community, which are good deeds, health, education, and social justice. This is reflected in our mission. Particularly, I like this part here. As a means of making evident the contribution of the Jewish community to the Brazilian society, because the Jewish community was taken by our Brazilian community during the past 200 years or so, but particularly after World War II. So the Jewish community has this strong feeling that they should do more for the Brazilian people in terms of recognition for the way they were accepted in the Brazilian community. Apart from that set of values and principles that that are the north of every decision that we make at Einstein, we decided recently in April 2014 to adopt the triple aim as a north of the institution. So all the strategies that have been discussed since then are based on the triple aim, and we're right now undergoing a big change in the organization with a bigger focus, particularly in population health. we have done very little in terms of population health. We have many things that were done in terms of experience of care, patient safety, quality measures, improvement, patient experience. We have been working out on reduction of per capita costs, but very little on population health. And today I'm going to focus more on this aspect here, efficiency, and I'm going to show you why in a minute. This is our structure. We are, in terms of management, we are divided into 5 big areas or big businesses, which are the hospital. The hospital is mostly at this unit, Morumbi unit. Diagnostics and preventive medicine, which is mostly located in our satellite units. Social responsibility, so we also partner with the government to provide services for the needy people in the public system. Learning and research, the Learning and Research Institute, and management and consultation. So the way we're organized physically is through different sites as a hub and spoke. So this is the hub, the hospital at Morumbi. It's a high complexity, big hospital. And the satellite units where we do mostly emergency department services, perform these services for the community, and also diagnostics. We are also growing very fast now in services in teaching, learning, training. So some of the satellite units now are dedicated to the learning part. In the as far as providing services in healthcare, we are today even or almost larger in the public setting than in the private setting. So Albert Einstein has been recognized as a hospital that caters for the most affluent people in the country. And it's true if you consider the private part of Albert Einstein, but if you consider the public, you can see that in terms of hospital beds and capacities, we are almost as big as in the public as we are in the private. The other characteristic of Albert Einstein is this obsession with accreditation and certifications in quality. So back in 1994, we already had some already some certifications with ISO 9000, American accreditation for blood banks. But most importantly, in 1997, the leadership of Albert Einstein was able to convince Joint Commission in America to come to Brazil and try doing its first accreditation for a hospital outside the United States. And that happened 2 years later in 1999. So Albert Einstein was the first one to be accredited outside the US. And since then, we've been collecting many different accreditations. We still don't have the Canadian one, but in our system, I'm sure we're going to find a place to test it. We're eager to test it. But we are struggling in my country. So people are sad today with all these problems, all these changes in the government. And some of you must remember a few years ago, there was this cover of The Economist magazine. And there was the Cristo Redentor, like this, but like a rocket. So Brazil, that was the future people were seeing for Brazil. That was back in 2009. So the whole world was undergoing this big crisis, and they were looking to Brazil as, you know, a country that was going counterwise. And more recently, this was one of the articles at The Economist, again, with a very lazy Brazilian man, resting, you know, we're not in a hurry, let's relax. And it tells about our economic problems, and it's mostly a productivity problem. So we have to be more productive. This is a mission for every Brazilian if we are to improve the conditions of our country and the level of healthcare and all the services for the population. So we've been discussing and doing lots of things in terms of efficiency and productivity, and this is what I'm going to tell you about a little bit of our, at least the positive experiences. So I'm going to tell you about some, this concept that we're developing of accelerating programs, a little bit about the way we organize some specialties as service lines and some centers of excellence, some collaborative programs. So I believe Enrique Ruelas has mentioned one of them, the Parto Adequado program, and how we're going about the AAA. So first I'd like to tell you about the accelerating programs, and the basic program that we are running is the patient flow program. And we're using now this program as a sort of a matrix to replicate for other issues that pertain to productivity, such as personal productivity, how we can change the mix of professionals at the different units of care at the hospital so that we can optimize quality and reduce costs at the same time. But first thing we needed to change, the first barrier or bottleneck, was this mindset that we had in the past. So this is a slide that we used. I used this slide many years ago as a mindset. You know, if we are to improve quality, that always happens at the expense of financial performance or vice versa. If we improve too much of financial performance, then quality is going to go down. So we have to change this mentality. We have to replace it. So now we're denying this view, this mentality, and trying to replace it with a new mentality that establishes a positive correlation between economic sustainability or performance and quality. And we can achieve that through efficiency. But to achieve that, we need very, very strong leadership to support it. So this is a new mentality. And we are trying to evangelize the people at the hospital, not just by telling them about a new mindset, but showing them good examples of how we can really make this happen, make this a reality. And this is one of the articles, and it's an article from Harvard Business Review, but it's also a book published by this professor from Harvard Business School, John Cotter. He specializes in change in organizations. And he recently did this work in which he compares the usual hierarchical flow charts or organizational flow charts in hospitals and other industries. So it's very pyramidal. So you have here the CEO or the boss, and then people who successfully respond to their superiors. But what we know, I know that you know this, is that there are many informal, very nice relationships between people at the local side, at the teams that are caring for the patient, and between administrative personnel and, healthcare personnel. And they all go out to meet outside the hostel, to drink beer, to play football. And when they decide to talk about something and try to improve or use some idea, they're very powerful. And they're able to, sometimes this hierarchical structure imposes new rules, new forms of, or new barriers for their work. And they are these networks of people, they are very resourceful in terms of bypassing these barriers, and they support each other. So usually what happens is that this structure here, which is informal, fights this structure and vice versa. So what he proposes is that if these guys are smart, they will use these people. They will give them, and not use in a bad way, but give them purpose, give them a north. And if they're really smart, they will work for the organization. These networks will work for that purpose. So this is how we, in fact, we were kind of doing that already with the patient flow program, and then we stumbled on those articles, and then we saw that that could be a nice reference for what we were already doing. So this is the hierarchy or the organizational chart of the hospital in terms of in this patient flow program. These are the teams that usually work out separately. They were not working together on patient flow problems. Usually these teams would kind of fight each other, point the fingers to each other when we had problems. So now what we did was we mapped using other industries tools, mostly flow tools or production engineering tools, to map out the whole of the patient flow. And we separated this very big flow chart in pieces that made sense. For instance, this is surgical scheduling. And we set up indicators that represented this flow and goals. And these goals are represented here in this dashboard, in this balance scorecard. And now these people here, this leadership, this informal leadership, is responsible for this, and they have freedom. They have some limits of what they can do because they already have goals, very specific goals, and indicators that they need to improve. But they have freedom about how to do it. Because the other thing we realize is that these people here are not the real people that know what's going on at the bedside. So we need to empower these people at the bedside, and the way we really empower them is to give them decision power. And we give them decision power about very specific goals, okay? So this is, again, the flow that we've mapped. And we use, we also provide the leadership that's taking care of that with training and many different tools like flow maps, Lean Six Sigma. We have 30 people that are dedicated in the hospital today just to train people, the other 12,000 people of the organization that are dealing with this program and with other processes that need to be improved. So this is some of just a snapshot of part of the indicators. In fact, today we follow around 140 indicators. So these indicators here are the most important or the more finalistic indicators, if you may. For each indicator, We have a track record. We have very specific goals. So this was the goal for 2015 for the bed turnaround, and the result we achieved that by the end of the year. We not always, these lights here, blue means we've achieved the goal, or green. Yellow means we were a little bit below the goal, and red means that we were very far from reaching the goal. So for many of these indicators and goals, we didn't do well. And we have a composite index that's a composite of all these indicators and the results in terms of achieving the goals. And this composite index is part of the balance scorecard of the whole organization. That means that the CEO of Albert Einstein is also himself, and all the employees are measured by this indicator by the end of the year in terms of performance. Some of these indicators, so the length of stay, this is probably the most important one. The bed turnaround. Some of the indicators are not as finalistic, but they are very, very important for the patient experience. For instance, the waiting time for a bed for patients that are at the emergency department. The average time for admission when the patient arrives for an elective admission at the hospital. And some of the actions are not just, engineering stuff. They are very sensitive things. So some nurses from the hospital visited some services, some hospitals in America, and came back with this idea that we should not and try to anticipate the discharge of the patient by sending a nurse to visit the patient at home after the discharge. But we should also do something better. That was to send the nurse to the patient home before the patient was admitted to the hospital. So that they could educate the patient about what was going to happen and how the patient should engage in his own care. So one of the things they teach the patient is how important it is for the patient to, right after surgery, the patient is still a little unconscious, the patient is still sleepy with pain, but the patient knows when the patient arrives at the bedside, to the bed after surgery, that it's important to engage in physical therapy right away. And that means that they have to sit by the bed. So the patient now knows that he needs to ask for medication, and as bad as it may seem, he should strive and make an effort to sit by the bed. This engagement led to a reduction in the length of stay for patients with hip arthroplasty, and the same for knee arthroplasty. In the past, 10 years ago or so, this number was around 10 days. Before that, 15 years ago, 15 days. And now it's reached 4.2 days. In fact, in 2015, it was 3.5 days. The other thing we're very worried, these are these indicators again, the reduction in length of stay, the occupancy rate of the hospital, but very important for us is the patient experience. So we want to do this and at the same time improve the patient experience. This is, it's the new mentality. And what we've been experiencing so far is that there is a reduction in the complaints by patients because the times are reducing and they don't have to wait for so long. They can go back home earlier and so on. And we also look at some other hard indicators, not just patient perceptions. So we have a track record of many years with following hard process indicators in terms of quality. Medication error, surgical site infection, central line associated infection, ventilator-associated pneumonia, catheter-associated urinary infections and hypoglycemia, and they continue to improve. That means that there was despite this focus now on efficiency, these indicators do not worsen. In fact, they improved at the same time. And the other thing is that by reducing the length of stay, we were able to save money in terms of not having to invest in new beds. And so far until 2015, by our calculations, we didn't have to invest in an expansion of the hospital equivalent to 74 new beds. And that, the prices in Brazil are very expensive, and it's about the same costs in the US for a new bed, which is roughly, if you consider everything that you have to do for a new bed, it's roughly around $1 million at Albert Einstein. So this is about how much money we saved in these years with this program. And you can see that well, maybe you've reduced this and you were able to keep the occupancy rate stable because you added new beds. But here is the evidence. From 2009 to 11, we increased 91 new beds. And since 2012, we added only another 12 beds and still were able to keep the occupancy rate very stable. Now I'm going to change for the other theme here, which is the way we go about service lines and centers of excellence. So one of the practices we've emulated from Cleveland Clinic is we publish our outcomes for some specialties that are more organized. And what we do in these specialties, we have managed protocols in the hospital. So we follow indicators and also hard outcomes. We have a team of nurses that call in the patient after discharge, for instance, a stroke patient, so that we make sure that every month or every 3 months, we know how the patient is doing and if we need to do something about that, if the patient worsens. And all these outcomes are reported in these books that you can download or you can navigate on them through the internet. So this is open for patients in Brazil. These are some of these outcomes that we display in our reports. Quality of life, function. This is just an example for hip replacement. But it's not just about looking at indicators and improving the patient quality of care. We're also experimenting now with some new programs. It's a new model. These are second opinion programs. So patients from a given insurance company, when the patient goes to the insurance company with a prescription for surgery by an orthopedic or neurosurgeon for spine surgery, the insurance company offers the patient for free a consultation at Albert Einstein for a second opinion. So more than 6,000 patients have already had this offer by the insurance company. And now more than 3,000, these are numbers from a year ago, displayed here. Now this number is more than 3,000. 3,000 patients accepted to come to the hospital. So in our program, we have a physiatrist or an orthopedic surgeon that does not operate on spines, but they're trained to evaluate the patient and see if the patient really needs spine surgery. And this is the result. Almost 60% of these patients do not need spine surgery. And why is it that there's so much over-indication of surgery? Because the incentives by the industry in our country are very, very perverse. So by offering this to the insurance companies, we are, saving money for the insurance companies, for the whole system, but mostly we are saving the patient of this risk of undergoing unnecessary surgery with all the risks and complications that happen after that. This is the calculation of the amount of money that's involved. Now we have, this program is very large today, and we have partnerships with 7 different insurance companies, larger, smaller. The largest ones in Brazil are already partnering with us in this program. And we're developing with them for high complexity surgeries like spine surgery or high risk surgeries, similar programs, not just in orthopedic surgery, but also in cardiology surgery and so on. These are some, of course, it's very important for us to follow the outcomes. And in this case in particularly, you can see that when you look at pain, dysfunction, and quality of life for patients that were subjected to surgical treatment, I mean the patients that came to us, we confirmed this indication for surgery, and they got surgery later. These patients improve in pain, in dysfunction, and improve their quality of life. And if you look at the patients that had an indication for surgery that was not confirmed by us, they have very similar results. And this validates the program. Now, shifting to the partnerships, when we were talking about with the Institute for Healthcare Improvement about things that we could do in our partnership, they were approached by Agência Nacional de Saúde Suplementar, which takes care of the regulation for private medicine in Brazil. And the issue was the very, very high incidence or percentage of C-sections in deliveries in the country. So we devised this program called Parto Adequado. It's not a C-section reduction program. It's not a vaginal delivery program, because we knew that, you know, society is very complex about this issue, and there are people that defend C-sections, and there are people that defend vaginal births, and we didn't want to enter this debate. We wanted to bring light to the discussion and show them that there could be a way to improve this. So this is where Brazil is today. This is percentage of C-sections and maternal mortality, so we're a very, very bad case. In fact, Brazil is, in a ranking of countries, is the worst country in terms of C-section rate. It's in the public sector, it's around 40–45%, which is very high. But in the private sector, it's 85%. This is the average of private hospitals. Some hospitals have 100% of C-sections. So this is the program. I'm sorry, there should be the hospitals here, but believe me, we have hospitals of all the big regions in Brazil. It's 42 hospitals. So the leaders of these hospitals are coming to have a training on the improvement science. They bring in their cases, so everybody learns with everybody's cases. We meet every month to discuss these cases. We are also training, of course, there's a hard part of it. We're retraining physicians and nurses and multidisciplinary teams on doing vaginal births safely. And we're also collecting data and using all the tools that we gained from the IHI. So one of the things we established was to set a goal for Robson 1 to 4. This Robson is a classification of risk of birth for the mother and the baby. And 1 to 4 means those mothers that don't have any good explanation for a C-section. They should do a vaginal birth because there's no possible explanation or indication for a C-section. So for these mothers, our baseline number was 34%. It's already, this was early this year. This is already more than 45%. And as a whole in the country, after 6 months of the project, we were able to decrease the C-section rate from 82% to 71%. Just as a background, this 10% decrease, it evolved in the past. There was this 10% increase from 2005 to 2015. And in only 6 months, we were able to reverse this to 10 years ago. These 42 hospitals today represent 85,000 births per year, and this is about 66% of all the births in the country. So it's already very significant, but now we're going for a scale up from 42 to 130 hospitals, and that's about 50% of the births in the country. And then on a third phase, we intend to make it whole, the whole of the country, not just for private hospitals, but also for public hospitals. And just to finalize, as I said, the triple aim now is our true north. So all the discussions at the board level, and we discuss strategy, this is always on our mind. We're not working just on the efficiency component. We're also working at the other components. And the main things that we're doing in terms of the triple aim are here under this strategic partnership with the IHI. So we became strategic partners a couple of years ago. One of the things that we did together was to establish a counterpart for the IHI forum that happens in America and in Europe every year. So we didn't have a Latin American forum. So last year was the first Latin American forum. It was held in São Paulo. We had 1,700 participants. It was almost twice the number we dreamed at the time. And this year is going to be Mexico. I'm going to tell you about that in a minute. We're establishing a Latin American alliance with hospitals that want to discuss what we can do as Latin America in terms of improving healthcare, what we can exchange between the hospitals and between the countries. The Parto Adequado, and now we are also trying one hospital of our network, a Latin American model. We're designing it for an accountable care organization. Let's say, not the Obamacare, as in America, they look at the negative part of the accountable care organizations. Of course, it's a big project, it has some problems, but there's a very nice part of it in terms of, it's a big dream. And it's inspired, in fact, in the triple aim. Concluding, sí se puede, but we need a new mindset. I think I'm repeating some of the things, some of the things here that all my other colleagues that presented already, more brilliantly, have said already. So it's a new mindset, a double mandate, and double mandate means that nurses in particular, when they choose to believe in this new mindset and they take care of the financial part of this equation, they empower themselves. Because now the CEOs will say, these people are coming back again with, asking for more resources or this or that. But they only think of quality, they're not looking at the financial part of the organization. Now, they are the major drivers of the financial results, and they empower themselves. more and better, we need more organization. We are a big mess, at least in our organization, we're a big mess of processes that we don't understand. They evolved chaotically like a living being. And we need to understand them to improve them. For that, we need to borrow skills and tools from other industries and adopt a new reference for value, which is the AAA. Now, I'd like to invite you, if I may, for the forum this year in Mexico. This was the forum. This is a picture of the forum last year in São Paulo. So this is Maureen Bisognano. She's a very inspiring leader. She was the president of IHI last year. And so we had this very nice photo of a display of Mexico City. So and we asked people to pledge to whatever they wanted to pledge to in front of that picture to inspire everybody. So she pledged to do more of Parto de Quadro or Parto de Quadro projects in Brazil at the time. Don Barrick was also there, so it was the first time in Brazil. It was very, very special for us, very emotional. And this year is going to be in Mexico City. So it's the 26th to the 28th of October. And in next year, in August, it goes back to São Paulo, but we intend to rotate in different countries, maybe next year in Colombia. We'd love to do that in 2018. And we hope to have some of these people that were there. You know these friends. This is Gary Kaplan, again, Maureen Bisognano. Claudio Lotteberg is the president of Albert Einstein. And this is Temporal. He's a physician. He was Minister of Health, and today he's the president of UNASUD, which is a congregation of ministers of health and secretaries of health of the countries of South America. So he's coming to Mexico this year. We hope this year, possibly, and next year for sure, to have with the leadership that's going to be there a meeting with the ministers, so we could discuss healthcare policies in different countries, what we can do as institutions to help. Okay, thank you so much.